Thank you for a kind introduction. So now, welcome to the webinar series for awareness building on DRG and UHC. It is the DRG e-learning. The core today is the module 1, the core understandings on DRG and health financing policy, which I try to speak from my almost 30 years of experience. The series of webinar after completion of the core and specific module of the self-assessment, you'll be able to utilize your knowledge on DRG to design strategic roadmap or adopt or adapt the application for DRG into the UHC framework according to respective role, and step up the experience on DRG by planning further education to fit with the appropriate stage of the UHC in the country. In this model, the scope will be on the health system building block, the universal coverage, the mechanism of health care financing, and the role of DRG in achieving UHC, and to know the essential elements to get the participants to get on board with the essential element for DRG and see the effect, the policy objective of the DRG payment. As most of us already know, the reference of the WHO in 2007 on the health system 6 building blocks. The health system building block cover the service delivery, the workforce, the information and medical product, vaccine technologies, financing, and the leadership and governance. The health system of this 6 building block should be provide the access coverage with quality to everyone, and the objective is the improved health of the population. The health system should be responsive to the population needs, and with the financial and social protection with the improved efficiency. This is the overall goal and outcomes of the health system. This 6 building block of the health system will be referred very often by health system reform and the payment method. To understand briefly about the universal health coverage, in the universal health coverage, this is from the website of the WHO, and it's described about to ensure all people and community to have access to quality health service where and when they need them without suffering from financial hardship. So this fits with the 6 building block of the health system very well, because all the health services should be accessible and without suffering financial hardship. Not only the WHO endorsed the UHC, the World Bank also endorsed the UHC, and it's in the website of the World Bank. It's explained almost quite the same, to ensure that people have access to healthcare that they need without suffering the financial hardship. And the goal of the universal coverage is at the highest level of international organization. It is in the United Nations website, or the resolution of the Assembly of the United Nations endorsed UHC as a goal, and it is mentioned as the 2030 agenda for sustainable development goal. And this is to support the universal coverage at the global level, to link the health system with the Sustainable Development Goal, or SDG 2030 of the United Nations of the UN. You can see that the action of the health system strengthening, of which the target of the universal health coverage, it will lead to meet the overall objective, the impact at the impact level of the SDG goal, especially on the SDG 3, equitable health outcomes and well-being of the global public health security. And not only this objective, the other SDG will achieve the spillover effect of no poverty with the gender equality and inclusive society. To achieve the universal health coverage, it's the mechanism of the health financing is very crucial. If you want to achieve the universal coverage, the adequate revenue, the adequate resources that is pooled, and when it pooled, then we purchase the health service. This is the mechanism of the health financing that will provide the universal coverage for the efficiency and equity of the using the resources. For the insurance model, it's quite that this when the pooling of the resources, it is the role of the funder or insurers to provide protection to the population, or when they become ill as a patient, and seek care from the providers. The protection of they can get access to health service, and direct payment will be reduced as the barrier of the financial hardship will be covered by the insurance coverage or the tax money that collect or pool. Then it's the function of the insurance or the third party to pay to the providers according to the services that patients or population come to utilize. And the payment method, there are many kind of payment methods, but in this sessions, we will focus on DRG. And we may focus on DRG within the global budget in order to contain the costs. And the alternative can be the capitation or the fee-for-service payment. But the weaknesses of the fee-for-service payment, of the escalating costs cannot be controlled. That's the origin. That is the cause of that we have to look for the DRG as the intermediate. It's the sharing of the pooling risk between the fee-for-service of higher cost and the capitation of the effectively control the cost, but it introduced the under services. Within the insurance model, there might be the moral hazard of A party or B party or C party. That means patients may use unnecessarily use service very often, and the provider may provide services under service or over service, or the insurers likely to pay provider uncomparable to cost. So in this insurance model, the governments or professional bodies come in to see whether the model is working well by controlling regulations or by monitoring. If we look at the role of the DRG that fit with the achieving the universal coverage, in this reference, the visual reference in 2020 summarized that DRGs of the US Medicare DRG, which had been researched since 1970s and come into implementation in 1983 in the US Medicare system. But however, as the US not achieve the universal coverage, even though they use DRG. After the introduction of the DRG in the US health system, in the Medicare and Medicare system, it's a spillover, or in these textbooks by Kimberly et al. They describe about the migration of managerial innovation from the book published in 1993, describing many European countries and Australia in researching and installing the DRG for the universal coverage of the Australian health system. I'll start with the Victorian state. and Thailand. We start the, but the Thai case is not published in this book. This book, there are many other European countries, and include Australia. In this WHO reference, there are many other countries that implement DRG to achieve the universal coverage. And the author of this book published 15 years later, again, expanding universal coverage of the Asian countries and many other countries. However, if we look at the framework of the universal health coverage as described in the cube with the 3 dimensions, the 1 dimension is on the population covered. It should, universal coverage, it should give the meaning of the almost all of the population covered with the policy or with the scheme, with the insurance scheme protection. The second dimension is the service covered. The service, health service, there are a wide range of prevention, health promotion, and many other things, treatment, like the in this publications that the populations are covered by different services. There are variations of coverage of different services in many countries, but for the DRG, describing the DRGs which cover payment for the acute conditions. So we assume that all the admissions for the acute condition is essential. So the coverage of services here, in this dimension, the second dimension here, if we use DRG to cover the admission of the acute condition, all conditions, so it will be comprehensive for inpatient service, and the cost of hospitalization is about 40% of the universal health coverage policy. It's quite big, taking the 40% share. And DRG covers all admission. We take a significant share of this, the second dimension of the cube. And the third dimension is the direct payment of the user at the point of care should be reduced. So that's the full meaning of the universal coverage by 3 dimensions. So now come to the part of the DRG itself. DRG, or the diagnosis related group, was first published by Professor Robert Fetter in the Medical Care Journal 1980. It is a patient classification system for acute inpatients. to measure the hospital output. And the patients in the same DRG, we have the same length of the stay and the same level of hospital resource use. I put this as a variety. If this is a variety of patients taking different shapes and different size, and how can we describe the product of the hospital? This is the research questions for Professor Fetter. During that time, try to describe hospital product, inpatient hospital product, in order to measure the cost and pay to the hospital according to the need of the Medicare to pay to the hospital. And if the classification of the hospital product is quite right, then we can put them into the several kinds, like a patient classification 10, 11, and 12, according to the shape of this shape, the same shape, but different size. And ending with 0 is a smaller size, 1 is intermediate size, and 2 is larger size. 2 is this shape, 3 is another shape, and so and so. So this is the classifications, the analogy for the DRG, for the acute inpatient care, if we can describe them. So the logic of the allocation of DRG, the research team, Fetter, and his team look at the information in the hospital and come up with the conclusion that essential information in the hospital can describe the hospital product or the DRG. So DRG is dependent on the diagnosis, principal diagnosis of the patients and the comorbidities and complications that variety of patients may have. So comorbidity is the conditions that come with the patients before admission. Complications is the condition arising while admitted in the hospital. Principal diagnosis, comorbidity and complications are encoded into ICD-10 at present. For the operating room procedures or OR procedures, patients may be treated with the operation, or in the hospital that may have a limited capacity, may not have performed the procedures. If procedures was done, then it's be encoded into the ICD-9-CM for US DRG, US-based DRG, or the Thai DRG, for example. And some others informations that describe the hospital product is the patient age and discharge type, right? Like the patient's discharge alive or patient die in the hospital, or the patients refer to some other institution. So the DRGs, once we classify into the same product, the patients will have the same length of stay and with the same relative weight or the hospital resource use, which we can describe them to describe the level of hospital, the complexity of the hospital as a whole as a case mix index. So in summary of the diagnosis related group of DRG, the patients we have it's the patient classification system for acute inpatient and with the ISO resource use, use of the hospital bed and the hospital cost, and use in the innovation as the prospective payment system that to contain the cost. There are some others patient classification system for others other conditions, health conditions. So we use the term case mix to be the more generic term of the patient classification system and cover all modes of care. And the principle of the classifications is adopt the same of the ISO resource group. The example of some other kinds of case mix, like the adjusted clinical group or ACG. This is the classification for the outpatient use of outpatient service, and the time period is for a year, and it can be used for the capitation on the risk-adjusted capitation, or the SNAP, the non-subacute and non-acute patients is the another example of the case mix that's used for the payment of chronic condition, for the subacute or the non-acute conditions, the rehabilitation period after the acute patients, after acute episode like a stroke acute episode, and the patients need the rehabilitation after the acute episode. So this is the case mix for SNAP. Once it's the trend, as the previous slides show, that it's the agenda of the WHO or the World Bank or the United Nations that the countries should go for the universal coverage for the 3 dimensions of the UHC cube. And it's very prevalent of the recommendations that since DRG cover almost 40% of health expenditure for universal coverage, then DRG is unanimously endorsed. So we would, this part of the webinar will focus on when we have consensus on the adoption of the DRG, how to get on board with the essential elements. I put it here that we need a dream team, and we need to have a good environment, financing power, the governance, and explain about the homogeneity and heterogeneity, and the information that we need. So for the definition of the DRG of ISO resource group, and that predict the length of stay and predict the cost. So we need the clinical information so that we can classify it into the DRG, and with the mechanism of the DRG grouper will automatically do the work for us. And the updating of the classifications into the whether to split new DRG or whether to collapse because they become ISO resource. This process is called the reclassification. And once when we have grouped them, we have to calibrate what the relative weight is like, or the cost weight is like. And after the updating the newer version of the DRGs, we call the process of recalibration. And for the policy of the payment, one relative weight is cost how much, and the pooling of resource, the collection of tax or premium, whether the funder have adequate resource to how much to pay, how much for the relative weight. This is the base rate payment policy, and the adjustment of the how much to pay for one relative weight is called the rebasing. Sometimes the patients are at the outlier, and then we have the to have the policies, the standards to what the approach to pay for the outliers, and the phase-in period. That means the once we pay for the average cost, the outlier, that means the high-cost hospital or low-cost hospital, we have the extreme effects. So in the introduction of DRGs, there's a phase-in period of how to pay for the one relative weight. And we have to, once we go on with the reclassification of the DRG or the calibration of DRG, and the to come up with the accurate policy. So it's the consideration of the accuracy of coding data, cost data that have to build up our own DRG is a very important consideration. So these are the concept that that to calibrate the DRG, what kind of course that we want to include, like some health system at the public and private providers, then whether the public had the salary covered by the government. So this the logic for the calibration on the cost, and the library for the classification of the DRG, and to maintain the several versions of DRGs. Human resource competency with different competence and adequate number. So as I said earlier, that DRGs, when we can apply DRGs with the global cap or global budget. This is to ensure that we can contain the cost effectively with the cap. So as I said, dream team to develop DRG for resource limited countries. When we the member countries of the UN want to achieve the universal coverage and to go on the further recommendation on DRGs within the universal coverage. It's very challenging that the learning of the DRG, continuous learning with the continuous research grant, very important to gain the knowledge. And the research grant for some countries may be very effective or very successful in seeking international budget, but at some point domestic funds had to be used for the sustainability of the learning. International inputs it's as the acquisition of knowledge can be from many means. The first is by research, and the other options is the study visits or the inviting experts to give advice. So this is the dream team is the core of the champions, the core member that have a different capacity. The capacity in terms of financing framework and the coding, the programming, or the audit, because that once you use DRGs, then there be the condition of the upcoding. Then these are example of the capacity of different people. And the dream team should look for the environment that's favorable for adopting the DRGs, that is the cost containment policy or the cost efficiency of the health system, overall health system. The dream team will look for the opportunity to exploit the information technology as the opportunity allows us, because they are cheaper and the everything is double the capacity within every 2 years. Involving teaching hospital in this bullet, that because of teaching hospital is the top level of the supply chain in the health system. So the teaching hospital should not opt out from the DRG, and this is the meaning of the dream team. Not if the dream team not covering the teaching hospital, but the dream team have to contact with the specialists from different subspecialties, so that our DRG get depth knowledge and how to deal with the complexity. So from the book published in 1993, they say that the fate of DRG will be successful or a failure. It depends on many factors, of which I put into the one word of the dream team. The dream team should know about the health policy context of our country, have a technical context, and have the key role to install all the elements with the internal and external efforts, and the effectiveness of the dream team, the path of entry. So, example of the need for the audit. Once we use the payment system, so to counteract with the upcoding, it enforced that we must have experts looking at the how to set the audit system, how to set the auditing standard to control the upcoding, and everything must be transparent, up from the classification and to the downstream of the payment or the post-audit of the standards or the clinical information or cost information. So these are the process. Must be transparent, must be spelled out to support the good governance system. For the technical part, statistics to address on the homogeneity and heterogeneity is the point in this following slides. As I put in the picture of the patient classifications, because patients have varieties of different shapes, different size. So the DRG is to classify them. So conditions in the same condition, in the same DRGs, will reach the maximum homogeneity. And if they are belongs to different group, they in terms of statistic, it should establish the maximum heterogeneity by the statistics. So within the classification, if they classify into the same DRGs, the coefficient of variations should be reduced, should be minimum. And once we classify them into different DRGs, because they have different shape and different size, then after the classification, we should reduce the variance. The reduction in variance or RAV should be maximized. This is the statistics will be described later in the subsequent webinar. Arithmetic means, or using the geometric means for calibration of the relative weights. This is the technical side that we have to consider to recruit them, into the dream team. The R-square for fitting the model of the payment policy. Payment should be flat rate or differential rate. The trim point of the outliers then are the example of the technical know-how. Coefficient of variations, the reduction in variance, variance in, if not split between group, and the variance of within group, how to calculate these. These are the formulas that the technical person should understand the data. The relative weights using arithmetic weights, arithmetic mean or the geometric means to pay for general case or to pay for referral case. Should we bundle or unbundle the items of the cost with the outlier payments? DRG is not fit for all. It's not one fit for all. So within DRGs, there are exceptions, especially when the technology of treatment was just first introduced. Then the sum of the items should be separated from the payment. Example for the COVID-19, the some of the many items of the hospital resource used to prevent the transmission of COVID in the hospitals, or the investigation, or the high flow oxygenation, ECMO oxygenation. It is separate from the DRG. Once when we understand it very well, then we can introduce them into the DRG. And this is the impact of the information that will be described later, that information is very challenging. If we consider back at the before the millennium, before the recommendation of the WHO, World Bank, and the UN, it's very it's when DRG was criticized that it's too complex for the old days. We tend to say that DRG is too complex, but after the millennium, DRG seems to be understandable and achievable. So that's the condition. Now, this is the brief assessment in the book of the NHS in the year 2014, that DRG has been designed to fit with the health system in different countries. And as mentioned in the 6 building blocks of the health system and the overall objective of the health system, that there are evidence DRG can increase efficiency in most of the countries, and also expand activities or expand service, enhance the patient choice, increase the patient satisfaction, reduce the waiting list, improve quality of care in England, in France, in Germany. So this is example that DRGs have proved to achieve the overall health system goal. So that's the first module of the webinar, and please follow the second module on the history of the Thai DRG development. That's the end of the first module. Thank you.
So thank you very much, Professor Supasit. So right now we are reaching the Q&A session. So I have seen many discussions in the chat box. So I will read out the very first question from Mr. Anand Vanasri. He is raising very interesting question regarding the definition of UHC. So his question is, as some countries may claim that they have achieved UHC, but it seems that the health benefit packages that are provided are quite limited, so not comprehensive. Can they claim that they achieved the UHC? So, Mr. Anand, you can unmute your mic to explain more about your question. So, Professor Supasit. So,
yes, as I put reference, take reference from the WHO publication 2020. That's the graph. Actually, not. We have to be critical. So, in my analysis, according to the 3 dimensions, if take inpatient only, I try to argue that DRG should be comprehensive, because if we look at experience from countries, some countries start with the 10 disease group and stay at the end with 10 disease or 10 DRG or 20 DRG. We cannot say that it's a universal coverage for at least for the inpatient, acute inpatient care. Yeah. So that's if we take the cube, UHC cube, then we have to consider the 3 dimensions and for each dimension, we should cover at least 80% or 90%.
ขอบคุณครับอาจารย์ Thank you so much ครับ
Okay, so I also saw the discussion with Dr. Fazila Aladdin. So basically, Dr. Fazila add on that SUSC focus only on financial hardship, and there is also a problem raising in the chat box that there is problem about waiting time. The waiting time is a problem that can be found in everywhere, even in the country with the best health system. Then we can encourage private providers to be part of the UHC system, then we could somehow address this issue. So maybe Professor Supasit, how would you respond to this question?
Yeah, I think my last slides that taken from the NHS publications that can answer these questions, that it's depends on the design of the system. DRG is just a tool, and it's a policy people in the dream team. As I said, if they set the waiting list as one objective of the accessibility, so the waiting list shouldn't be long. And in England, according to the last slide, the slides before the end, that they say there is evidence to prove that it reduces waiting time, or and even improve the quality.
I see, Professor Supasit. So right now there are another questions about Taiwan healthcare system. So Taiwan is a single payer system, and Taiwan also involving the private providers. So this question raises from Mr. Benedicto. So does Taiwan updated DRG prices, of course, annually? So over to you, Professor Supasit.
Yeah,
maybe there is questions. I saw that many discussions regarding the Taiwan healthcare system and the DRG.
Yeah.
So what maybe you can explain more about the DRG for the Taiwanese healthcare system.
As Taiwan is a single payer, and they use DRG, and yeah, it suggests advisable that DRG should be updated currently. So it's a proof that the USS system calibrate every year, and other countries very often biannual, every 2 years, and the DRG or HRG in the UK also have updated almost every year. Australia maybe we can study this in their website, but Taiwan, I think they should update it, but I have no knowledge that whether it's updated annually, but almost advisable to have a current situation. For the Thai DRGs, we update to the version 6, and it's quite 5 years already.
Let's see. Thank you, Professor Supasit. So I saw Dr. Punchai Kisanayotin raises his hand. So
Yes, I saw the discussion, and I would like just to add in that, to my knowledge, I have visited Taiwan several times, and also asking about their success at universal healthcare coverage in Taiwan. To my knowledge, it's true that it's single payer. There is no gatekeeper, and also most to my understanding that they pay fee for service. They have a kind of the schedule that how will they pay for each resources, and it seems like those are also the burden of their system, and they are considered to. It seems like they are learning and trying to develop the DRG. So this might be not very update, but at least last 1 or 2 years, they're still working on how they would like to replace the fee for service with the DRG. They maybe has some pilot project on the DRG. That's what I learned from our colleagues in Taiwan. It's unfortunate that we don't have the Taiwanese in this webinar. Otherwise, they will ask maybe discussing more on that.
okay.
Over.
Okay, thank you very much, Dr. Bunchai. So I saw another question. This is from Ms. Tiffany Monica. So is it possible for 2 tiers social insurance with DRG payment system, having coordination of benefit scheme with private insurance, indemnity and reimbursement? Yes, Professor Supasit.
Yeah, it's possible. I think it's possible because DRG is more or less like a tool, and it's a calibration of the different product. So it's up to the governance, as the question asked on the, if it's 2 tiers. So it depends on the policy or the governance objective of the detailed scheme. Want to protect on what, give protection on what, and so and so, and adjust that for the according to the policy framework. Like in Thailand, we have three schemes, so they use the same tool, but pay differently according to their explanations.
Okay, thank you, Professor Supasit. So there's another question from Dr. Fasila. So actually, I'm curious the same thing with her. So Dr. Fasila asked, so what is England doing right? I think she means the tables comparing between several countries, and England have, I mean, the ticks in every rows. So in your opinion, Professor Supasit, is England doing right?
Yeah. Why I put this reference in my presentations, I tend to say to my mind that is it biased because of the NHS publications. So there are a lot of ticks. I might say that the UK system, they explore on the DRG, and they have a different name for the DRGs. they address it as a HRG, Healthcare Resource Group. But I think it's there are very quiet details, or because we have a good access to English publications, so that may explain the success of the DRG objective that fits with the health system objective in many roles.
I see, Dr. Supasit. So Dr. Punchai raises his hand. So please welcome Dr. Punchai. You raising hand, right?
Yes, thank you. I think to this point, I think I would like to have some kind of the comment. So we're talking about the UHC, and now we're talking about the provider payment system. This is the different things. It seems like we would like to achieve the UHC. The UHC has a very elegant, beautiful goal that everyone will not have access to healthcare without hardship, and also have a quality of care. And they have we have a 3-dimension to measure what is the UHC. That one part. But once that policy wants the UHC, then there is many provider payment system like the Taiwan. Taiwan is reached UHC for 20-30 years, and from that point they pay like the fee for service, and they don't use the DRG. So their provider payment system is not the DRG. So the DRG is just another financing tools. And why everyone trying to learn the DRG? Because of they cannot, to my understanding, they cannot afford to do the fee for service. And at the same time, if they some country just want to say that they achieve the UHC by paying the provider with the fixed rate, with the capitation, then the issue of poor quality healthcare arise. And that's why, to my understanding from learning from Dr. Supasit and from working with the information with the DRG, I understand that the DRG is kind of the in between both provider payment system. I don't know, some country maybe have to consider. So that's why there is so many variety and many detail on the shade of case mix. Let's say that case mix, because of DRG originally is acute care, and I just learned today that the acute care accountable for 40% of the what we say the UHC, maybe costing finance in terms of the money use and resource use. So it's not the panacea, it's not the magic bullet for the UHC, but it's one of the tools that going to that. That's what my understanding. I'll finish this.
Okay, thank you. Thank you very much, Dr. Bunchai. There's another question come from Willis Diane Hadayani. So Professor Supasit, is there any standard for the CV value? And how can we say that the group in one DRG is homogeneous?
Yeah. So it's quite a bit arbitrary. So at some point we set the CV at the 1.5. That means the standard deviation is very wide, but some can set it at 1, or the as I said, it's arbitrary. And for the RAV, from the history or the review of literature, the acceptable set version of new set of DRG that the reduction in variance should achieve 30% of variance reduced.
Okay, Dr. Supasit. So here's the last question. So it's from Daya. So the first question from her is, could you elaborate more with case example on reclassification and recalibration issue? What should be considered? And second question, according to your opinion, in which case an unbundled payment is still necessary?
Yeah, the reclassifications take COVID infection. Should we put COVID infection in the pneumonia or in what? Because now we are quite have good understanding of the COVID patients, so it may not be may not need separate classification for that, or to be a new DRG, because it's more or less it depends on the condition of pneumonia or the comorbidities. So this is a kind of whether we need reclassification. Yes, we need reclassification once we understand the clinical manifestation and the cost resource spending for them. So as the one of the slide explained that when we first know the technology or first know the condition, we tend, because we don't know the homogeneity or heterogeneity for sure, then we unbundle it. It should not stay within the DRGs because it may have high variations within that. Example that exists in the Thai DRGs of the payment for the cancer care. We unbundle the medicine, the protocol according to medicines from the DRGs, and we pay the rest, the admissions overhead on the DRGs, but on the adjusted formula. We call it adjusted formula for cancer.
I see, Doctor. So I think we reached the end of the webinar. So as you know that this DRG webinars have 5 modules. So the next module gonna occur in May 4 at 8 p.m. Manila. So I hope I see you all there again. So thank you very much, everyone, for participating in this session.
Thank you very much.
Dr. Alvin, do you have anything to say before closing this webinar?
Just wanted to say thank you to adjourn Professor Supasit. Thank you for your knowledge and wisdom. Look forward to the next webinars. Thank you.
Thank you for good discussions.
See you all in the next webinar.